Good evening to one and all. Welcome to this month's Tempo Conversation on Mental Health. My name is Mariska Peter and I'm the Corporate Biokineticist at Bestmed. As our guest speaker takes us through this evening's talk, we'd like to invite you to sit back, relax, and enjoy. Our talk is about 45 minutes, and thereafter that, we will open the platform for questions and answers. Please feel free to use the chat functionality or raise your hand by using the hand icon to answer your question. It is my privilege to introduce our guest speaker for tonight, Lucinda Sebekulu. Lucinda is a clinical psychologist by profession. She has a passion for wellness matters, and this is combined with extensive experience in the public sector, which has led her to become the co-founder of Psyched, the online counseling platform. Within Psyched, her knowledge base and skill set has been critical in developing the best of breed technology, which translates into face-to-face intervention onto the online environment. Her qualification was obtained from the highly recognized Makatu Health Sciences University, formerly known as Medunsa. She has trained in a variety of therapeutic modalities, which affords her the opportunity to provide psychological expert opinion on different matters relevant to South Africa's landscape. Without further ado, we hand over to you, Lucinda.
Thank you very much, Mariska. Thank you very much for that warm welcome. And as we start with this evening's session, to start challenging everyone who's out right now without having to share much around what is it that you know and how much do you know about mental health and how often do you take care of mental health? Do you take care of your mental health as you do in this presentation, as you listen, challenge yourself right this evening and start making decisions, if you can, around changes that you may potentially want to introduce to your life. So, what I'm taking is major depressive disorder, which is bipolar mood disorder. Yet again, another disorder that we hear quite a lot about, where we hear quite a lot of people saying to one another, you've got bipolar disease. And often with my presentation, you will understand that this is a serious mental illness. And then lastly, I will give you a brief overview regarding the Bestmed Temple Wellness Program and what it actually offers you as a member of Bestmed. So just to kickstart with major depressive disorder, as I said, it is what is commonly known as clinical depression. Often than not, yet again, it's another word that we use quite loosely. We all say, I'm depressed. From time to time, I woke up depressed. I've been depressed for the past 2 weeks. But the question is, are you really depressed or are you stressed? Because there's a difference. Often serious connotations to it, whereas it comes with various changes to one's life, and those changes literally will affect a person's functioning right through from the morning all the way up until one goes to bed. So to start off, let's just start demystifying that which we think we know about depression. Depression and stress are not the same thing. What is stress? Stress is often when we are feeling just frustrated about certain things not going our way, feeling sad because something has happened. And we may actually feel like not even interacting with people. That can still be stress by virtue of the fact that often than not, it would be a result of something has happened, meaning that something has happened that leads to that particular behavior. Whereas with depression, regardless of whether something has happened or not, you would find that the individual who is now diagnosed with clinical depression finds that The way they feel gets to be affected. The way they think gets to be affected. The way that they behave is also affected. And at times, it also extends to one's physical health. And that is when we start, as clinicians, we start to say that a person has got what we call somatic symptoms. This is when a person starts to say, I have this headache that doesn't go away. I've got this tummy ache that I always have. Sometimes we experience those particular symptoms as a result of depression, but I will be giving you a holistic view of how these will then end up actually interacting with one another in order for us as clinicians to then say, we are now giving a diagnosis of depression. And what is also important about differentiating between depression and stress is that with stress, you can be stressed about your work, but you still get home and you're functional. You can be stressed about what is going on at home and you get to work, or one goes to school and they're still functional. Whereas when it comes to depression, what we find is that once a person is clinically depressed, they actually experience a significant impairment in how they conduct their lives. This would affect most areas of functioning. This could be work for somebody who's still at school. This could be work, or it could be school, social activities, and even the relationships that a person has with loved ones and with individuals, perhaps colleagues, for example, or individuals who are part of the social system that they actually exist in. Now, as part of now differentiating between what is normal stress and what is depression, I'll take you through what the symptoms actually look like. This would look like a person who is continuously sad, person who would say and not, you'd find that the individual cause what comes from individual is that a person who's clinically depressed, it looks like someone who says, I enjoy having now what might happen is I think I lost you there for a bit. Is at a point where we speak about a person who's interest in activities that they previously enjoyed, and also a person where you find that they lose their appetite, or they start to eat more than they would have in the past, or you find in their sleep patterns actually get to be affected. What we also find, there would be a slowing down of physical activity where the individual struggles to take part in physical activities, where you find that they sometimes even struggle to engage and talk with
Lucinda?
people, or you find that the individual.
Lucinda, can you hear me? Apologies for interrupting you.
I'm here.
Kindly, may I ask you just to switch off your camera? We see that the reception is not too good. We have a lag. Apologies for that. So we're trying to improve the reception going through. If you could then just turn off your video so the sound is much clearer. Thank you.
Thank you very much. Apologies about that. I'll just continue where I left off. And that was, I'm just sharing my screen for now. Okay, I was just indicating that what would happen is that would want to spend time with family. They would not do things that they previously enjoyed in the past. What you may find is that a person claims that they don't have an appetite, or what you may find is that a person starts to eat more than what they would normally would do under normal circumstances. Or else you find that a person has got changing their sleeping pattern. Wake up in the morning, I don't want to get out of bed. And I know many of us listening in this evening can actually relate to this, can't we? Where we think sometimes I'm so tired, I'm so fatigued, I feel burnout, I don't want to wake up. However, what the differentiator when it comes to depression is that your sleeping patterns get to be so disrupted that a person stops realizing that there's something wrong with what they're doing. They stop realizing that they can change certain things, because most of us dedicate to having days when we're really tired, we don't want to wake up in the morning. However, because we've got responsibilities, we are able to mobilize ourselves and actually force ourselves to literally take a shower, have something to eat, and go to work or do some work or play or do some activity that would have been planned for the particular day. So for someone who's depressed, they don't even have that appreciation. Instead, they would literally sleep in, and somebody who's employed would often not be the person where it would be said, Lusanda, she's gone away, not reported. When friends and colleagues check up on Sunday, you find that the person is in their apartment, but they just don't have any motivation whatsoever. What we also then find is that such a person would claim that they're really tired. This point that is a huge task. Even talking, you find that they really struggle with talking. And what we also find is that such individuals get to be highly agitated, and you find that they are restless, and often than not, you say or do one thing, and they really frustrated and upset with you, and you don't even understand as the next person as to what is it that I have done to upset person A. I also started fatigue early on and depressed. I said it also affects our physical health. And that is where you then find that there is low energy. I'm just going to check with you, Mariska, if you can just give me an indication. You still hear me?
We can. It breaks up now and again, but it is due to load shedding. So we're going to then have to carry on, but it's much better.
Thank you very much. Give me just a minute. I want to see if I can change connection on my end as well. I'll be more audible than I was before. Apologies about that. My network is a bit compromised due to load shedding, but I will continue. What you then find with someone who's depressed as well is they will experience a persistent feeling of being worthless. They will claim to be guilty about certain things. The fact that they're depressed also makes them even more guilty. The fact that they struggle to engage as they normally would in the past makes them feel even more guilty. And what you then find is that that particular person would then struggle to make decisions. They struggle to concentrate. And often than not, you find that right at the end, they start to have suicidal thoughts where they start to think that ending their lives would be better. Now, I mentioned that some of us sometimes will experience these symptoms, but for us as clinicians to actually give a diagnosis of clinical depression, we look at the number of symptoms that the individual is having, and we look at how long the individual has had those particular symptoms, and we look at whether they're able to mobilize themselves out of that particular mood. Now, what causes depression? Because that's a concern that many people have. And often than not, yes, it is an imbalance in a person's brain chemicals That's the first part that we need to understand. And the reason why I mention this is because some people will actually say to a person who's depressed, snap out of it, contain yourself, change your mindset. Now, for someone who's clinically depressed, it's not an easy task, because what is now happening is there's now an imbalance in how their brain chemicals are actually functioning. And the causes thereof is sometimes it is genetics. If someone in the family already has had a mental illness, you may find that a child will also develop depression. You may also find that a person who's been exposed to certain traumatic life events or certain illnesses, for example, someone who's been a victim of child abuse for the longest time, or someone who's in a relationship where there is any type of abuse that actually exists, you find that that person is predisposed to actually developing clinical depression. And sometimes you may find that it would actually develop without a clear trigger. And that is when a person would actually come to a clinician and say, I don't know what happened, everything was fine. And what we then find is that when we engage with the individual, that is when we actually realize that a particular person has had something happen in the past that they never dealt with. And therefore, what ends up happening is you find that they then develop symptoms of depression slowly without realizing it, where it's one symptom here and another symptom there. But because there is no conscious awareness of what is happening, and before a person knows it, they've now got this full-blown series of symptoms that they're experiencing, which now start to affect their full-on functioning. Now, it's important that I also mention to you this evening that depression is not only a disorder or a mental illness that adults get to have. Children and teenagers can also develop depression. And the symptoms are almost the same. So what I've mentioned would also be evidenced when it comes to a child or a teenager. But over and above that, there are certain behaviors that we often see with our children. For example, a child is suddenly clingy, does not want to go to school. When you drop the child off at school, doesn't want to get off the car. Sometimes you find that they are developing symptoms of depression, maybe because of bullying, or because they feel that they're not good enough, because they're not passing their studies at school as they hope they would. And sometimes due to the pressure that a parent may be putting on the child to say, I only want you to get A marks and nothing below that. And what you then find that with children who then develop depression is that they start to have these random feelings of worry, where they're just worried about things going wrong. And each time you want to follow up as a parent, you want to follow up as a caregiver around what the source is of this, you find that the child can't give you something quite specific around what is causing this. So these are now telltale signs for you as a parent to start observing and to start exploring as to what is happening. And what we also see with children is they start to have these aches and pains that have got no basis whatsoever. You will take the child to the doctor says there's nothing wrong, doesn't want to go to school. All of these behaviors are ultimately geared towards avoiding interacting with people, geared towards not going to school and interacting with other children. You'd find that perhaps an 8-year-old may suddenly start bedwetting, which may have been, something that they would have stopped at the age of 3, for example. You find that they stop eating and they actually get to lose weight. Now, with teenagers, yet again, there is an overlap in terms of the symptoms, but often than not with teenagers, what becomes the telltale signs is how they claim to be feeling negative. They claim that they are worthless. They claim that they don't belong when it comes to their social systems at school. You notice that there's a poor performance. You get reports, and those are things that parents need to look out for, where you start to get reports from school to say that your daughter or your son is not attending certain classes or is continuously crying in class. And you find that when you ask what is happening, they'll often say that people don't understand, yourself included as the parent or the caregiver. you find that they become very sensitive. And you find at times as well that they really do not even want to interact with anyone. Anything that looks like a social interaction, they don't want to engage in. Now, again, when it comes to just the different age groups, because it's important that we also get to understand when it comes to our parents also can suffer depression, but often than not, we find that it often goes undiagnosed and untreated because family members will think mom is getting old and so she's getting grumpy. Grandfather is grumpy. Yes, we know there is something that looks like, a person who's being grumpy, but sometimes you may find that there is depressive symptoms that are creeping in. So I'm saying to you this evening that when a person of old age starts to exhibit depression symptoms, it's not particularly a normal part of growing older. I do acknowledge the fact that, yes, there are certain mental illnesses that older people may develop, where you may find that there'll then be an overlap with depression, for example. But ultimately, what becomes important is that we take note of such and we have insight into this and we push for them to actually get the help that they need. Now, what the symptoms would look like is, again, almost like the normal symptoms that I mentioned in the beginning. But what you would find being added here is there would be memory difficulties. Yes, again, a key feature of getting old. Or you'd find that there'd be personality changes. You'd find that there's now these physical aches and pains. Again, another feature that we see in people who are of age. But again, you want to, as the son, as the daughter, as the grandchild, you want to also just take a bit of a meta perspective and observe when and how these particular symptoms actually get to take place and how often and how they actually affect the particular older person. They would often complain about being tired. They don't want to eat. They're not sleeping. Or you may find that one loses interest in sex. And this, by the way, actually applies to even individuals who are of middle age, where you find that, like I said in the beginning, things that people used to enjoy, they no longer want to partake in. And for us to say that this is now depression, because we do also acknowledge the fact that sometimes some symptoms can be caused by perhaps side effects of certain medications that an individual may actually be on. So before we actually give a diagnosis, we do look at that. And if we realize that actually there's a medical condition or there's medication that the individual is actually taking, which could cause and account for those symptoms, then we do not give a diagnosis of clinical depression. Again, the self-isolation is something that is always there. And if we think of older people, often than not, you'd hear them say, I wish I was just dead, because there is nothing else that I'm living for in this life. And it's important that we take note of this. It's not just because they're saying I'm now old, but what they are communicating is that there is internal chaos that is happening within their emotions. And so us responding accordingly and appropriately becomes rather important. Now, how do we treat clinical depression, MDD as we call it, major depressive disorder? There's medications that an individual would actually get from a mental health practitioner by way of a psychiatrist. And often, again, we hear of individuals who would say, I was given medication and I started getting sick, I started gaining weight, and therefore I stopped. Now, it's important that we always understand that with any and all types of medications, sometimes you may have to be started on a certain regimen of medication. And if it does not work, you want to report this to your medical practitioner so that they can actually switch the medication or add whatever other medications that may be required in order to start managing the symptoms that the person is actually presenting with. And then what we also recommend is that a person gets to attend therapy. Now, when it comes to therapy, again, people would often say, no, it's a certain type of therapy that would work. There's many therapeutic modalities that psychologists would actually tap into, and what informs what type of modality is actually implemented with a particular person is dependent on what it is that they present with. When the symptoms started, based on the clinical interview that a clinician would actually have with an individual, if they realize that, for example, symptoms started quite early in life, what that then communicates is that there are other certain types of modalities which will need to be activated in order to deal with perhaps repressed traumas that a person has had in the past, or any type of challenges that they experienced but never got a chance to actually deal with. Now, many people would actually ask, what is therapy going to do for me, Lusanda, if you say that it's a chemical imbalance? We already have the medication in place, but sometimes we also need to look at how a person perceives the world, how they interact with the environment. So that is where psychotherapy then comes in, where there now comes in a point where there is behavioral management, where a person gets to learn what types of distorted perceptions they hold and how these can get to be changed, because medication will help with the imbalance, but medication will not necessarily show you exactly where your challenges lie when it comes to your perceptions. And what therapy also deals with is, in therapy, we look at how the depressive symptoms that a person presents with, how they then affect their relationships, and how a person can then be capacitated with skills to improve how they engage in their relationships. And further to that, it's important that we always acknowledge that stressors in life will always be there. But because the person has gone through the psychotherapy process, they learn to identify stresses as they just come through in their lives. And because they've been capacitated on how to manage them, they are able to immediately start with implementing whatever measures they would have learned within the psychotherapy space. Now, for now, I'm then going to be pausing on depression, and I'm going to take you through bipolar mood disorder. I mentioned earlier on that often than not, people will say, so and so is quite moody, just because a particular person has got what is termed in inverted commas, mood swings, where you find that they have just got this noticeable change in their mood that can be quite sudden, that we can't, particularly as people who are around the individual, actually understand as to why Lusanda is now upset. Now, for us, again, as psychologists, when we interact with individuals who present with mood swings, you find that it's not that this is now an unpredictable change that just comes out of the blue. Often than not, you'd find that something may have happened. For example, you have an issue with your manager about a report that you were supposed to be submitting as an employee. And you actually get upset, but because this is your manager and this is a person who holds a position of higher authority than yourself, you find that the person actually opts to not address that. But what happens is when they get home, where you find that now they are the persons who are in a position of authority, that is when you then see that mood then changing. And for a person, when you ask, what is wrong, so and so, I don't know would be the answer. That is when we start to say, so and so has got these mood swings. Whereas you find that when you do exploration around what has happened, you actually realize that this person had been upset by something that they couldn't particularly address at a certain point. And what ends up happening is they then almost, if I'm to use again in inverted commas, they take it out on their loved ones at home, hence then being labeled as having these mood swings. Now, there's a difference between the mood swings that I speak of and what we term bipolar mood disorder. For short, we call it BMD. Now, having a mood swing is not a mental illness, but it is a characteristic of certain mental illnesses. And I'll give a quick example, because I know as you listen, you may then say to yourself, no, but a mood swing is definitely some sort of illness. But what you find with such individuals as well is that the fact that one takes out their stress that was instigated from work and they take it out on their children at home is communication that perhaps when it comes to their personality structure, there is certain limitations that they have. I'll give you an example. Such a person would be struggling to regulate their emotions. Hence, then you find that they get so upset suddenly with no particular trigger at that point. So such individuals, you would find that they are picking from different types of personality characteristics, which we call, we've got a big classification of personality disorders. So you find that a person may pick from your narcissistic personality disorder characteristics, would pick from your borderline personality disorder characteristic, and that is when you start to see these mood swings. But essentially, they are not necessarily bipolar mood disorder. And it's important that we understand this because it allows us to start holding people accountable, because what we do as family members, as society members, in the different workspaces that we belong in, we see this and we start to normalize it. We start to say, Lusanda is coming in with that mood of hers. We say that today it's one of those days, whereas such things do need to be addressed because essentially they are not necessarily your full-on mental illness diagnosis. Now, what is BMD, bipolar mood disorder? It is a mental illness that actually brings severe, and I say it again, severe high and low moods. And how these moods then get to interact with the person is they actually bring a change in their physical, their emotional, and their psychological functioning. Now, when we say severe highs and low moods, what this look like is they literally are like two poles of a mood where you find that the person is extremely happy, or on the one end, you find that the person is extremely sad. And that is why it is called a bipolar disorder. Now, with bipolar disorder, what we see is we see a person having what we term manic episodes. And those are the times when people will be labeled as having highs, where you find that they've got high energy. They are super happy. They are highly energized. They are highly motivated. They want to do anything and everything under the sun. For example, someone who is religious, you find that they start to present with what we call hyper-religiosity, where they will pray and they will start preaching, depending on what their religious affiliation is. And they're convinced that they can change the world, and they're overly optimistic. And because they are on that high where they've got so much energy, they would then struggle to actually sleep. And you find that a person has a report by the time they're brought in for an assessment, we would be told that so-and-so has not slept for the past week. And that is because genuinely they've got that much high energy. And when that happens, often than not, once we get to that stage, we find that individuals start to get impulsive and they struggle to make proper decisions, and they start to lose touch with reality. This is when they start claiming that I have got superpowers, because it will start with, I am praying for my family. And then it will be, I am now a prophet. I have been identified by the higher power as someone to actually replace him or her, depending on what they believe in. And they may also find themselves experiencing hallucinations where they start to hear things that none of us can hear, start to see things that we can't see. They start to sense, and they'll say there's certain smells that none of us can actually sense. And what you then also find is that whilst they've got this high energy and they're so happy, you find that when they have this switch, it's quite sudden. Literally, you'd be engaging with a person and just out of the blue, bam, they're irritable, they're angry, and they start getting hostile. And what you find is that with these symptoms is they can last for days to months at a time. And sometimes then you find that the person may then start to say, I'm feeling suicidal. Now, on the other end of the spectrum, when we speak to the depressive episode, which would be the low, as what would label it, you would see those depressive symptoms that I mentioned to you when I was speaking about clinical depression ultimately. And again, there would be no particular trigger that is overt for anyone to say, we saw what happened for him or her to actually feel this way. Now, what ends up actually getting to confuse sometimes when it comes to family members is that while sometimes they're in between these moods, you may find that there'll be a brief moment when things actually get to look normal. And it is when things actually get to look normal that people will actually say, no, then there's no need for us to seek help for Lusanda. And sometimes it's also important that I mention that the sequence in terms of how the symptoms get to present in terms of the high and the low, there's no particular pattern. You may find that a person may just continuously be manic, and then out of the blue, they then switch to depressive, and it goes back and forth. So there's no particular sequence that we actually expect to see. And as such, how one person actually appears, person A and person B is not the same. Now, there are also different types to bipolar mood disorder that would often be diagnosed, and that is bipolar 1, and there would also be bipolar 2 disorder. What is bipolar 1? It's what I was just describing to you, where you find that you've got this extreme polarity in terms of mood, which ends up resulting in this erratic behavior. And often than not, medical care would then be indicated. And what you would find is that when a person goes into the low, the part where they now go into the depressive episode, it is extremely low to a point that you can't even get them to talk at times, or else they would even, at home, you may find that the person locks themselves in their room. They don't want to switch the lights on. They don't want to open the curtains. They don't want to bath. They don't want to interact with anyone. Bipolar 2, on the other hand, yet again, also just like bipolar 1, has the highs and lows. However, they are less extreme. And what you may find is that such individuals will not necessarily get to a point where they become psychotic, where they have got delusions, where they believe that certain things are happening to them, or they can see certain things, or they believe they are certain people. And they wouldn't also have what we call hallucinations. And what you find is that the symptoms, as much as they are present, may not necessarily impair their functioning when it comes to their daily life. When it comes to bipolar mood disorder, there is no particular single cause. As it is, research is still being done as to the causes of bipolar mood disorder, because individuals present differently. So for other individuals, it may be genetics. For some individuals, it may be environmental factors that a person is actually exposed to. And for some, it can start in adolescence or young adulthood. And when it comes to prevalence, you find that both men and women can actually get to develop bipolar mood disorder. Now, for a diagnosis, one needs to see a mental health practitioner. And as I indicated before, when we want to be diagnosing, we look at a holistic view around what it is that a person actually presents with. Now, when it comes to treatment, yet again, medication comes in. Therapy, just like what I said around clinical depression, and also lifestyle changes become important, and social support. And I must mention this, it's quite important, because bipolar mood disorder is one of those mental illnesses that are often feared. People can lead normal lives, even whilst they have that diagnosis, because they're managing it through the different treatment modalities that I'm actually speaking to right now. And yes, like again with depression, sometimes it can take time for the right combination of medication to be actually discovered for a particular person. Now, when it comes to lifestyle changes that a person can actually adopt, it's exercise, it's your basic self-care, eating, sleeping, and monitoring how you're doing it, and also learning how to recognize one's mood swings so that you know how to respond and seek intervention quite speedily. And also ensuring that you've got a good support system, keeping a journal around your symptoms so that when you see your mental health practitioner, you know exactly when it started, what happened before everything started, and also learning how to manage your stress, and also adopting healthy hobbies, and perhaps adopting certain sports as you likes, and also avoiding alcohol or recreational drugs. Now, the last thing that I'll just take you through for this evening is Bestmed has introduced the Temple Wellness Program. And what the Temple Wellness Program does is it takes you on this beautiful journey as an individual, where even if you don't necessarily have the symptoms that we spoke about, but I alluded to the fact that we all experience stresses. And so because you're an individual who's continuously exposed to different stresses, you would have access to a library of information and resources that would help you to know how to identify, understand, and accept your emotions. And you would get access to articles on different types of topics that are relevant to your wellness journey, as well as access to various exercises that you can do to improve your emotional and mental well-being. And these would include videos and breathing and meditation exercises, muscle relaxation, mindfulness exercises, and the likes that would help you maintain your wellness journey. Now, all what this information would actually help you as a Bestmed member is it would help you to achieve your desired emotional and mental state. Remember, all Bestmed Tempo benefits are offered to members free of charge, regardless of one's benefit option. And if one has any query, they would need to then communicate with the Tempo team. On that note, it brings me to the end of my presentation for this evening. I will get guidance from Mariska around questions if there are any. Thank you very much.
Thank you, Lucinda, for that very knowledgeable and interesting talk. I'm going to open the platform for any questions. You can then use the raise your hand icon on the reactions button, or you can then just pop in your question in the comments checks functionality, and Lucinda will then answer your question. See, we have a hand raised from Wendy. Wendy, can go ahead.
Yes, thank you so much. Good evening. Thank you for having this presentation. It really helps me and my family a lot. So my question is for my daughter. She's 29 years old. She is a lupus diagnosed patient, and she's had 2 psychotic episodes, and she's a patient under the neuropsychology at Grootersdorp Hospital. My question is, she's just now been diagnosed with bipolar 1, but I'm confused looking at all the factors that Lucinda mentioned. She's almost got a bit of a combination between bipolar 1 and bipolar 2, because she has extreme manic episodes, but her lows are not that low. So does it take a while before these symptoms can be clearly identified and a proper diagnosis of either bipolar 1 or bipolar 2 is then given? Thank you.
Thank you, Wendy, for that question. When it comes to the actual diagnosing part, as I mentioned, and as you rightfully say, they would want to look at the different polarities and how extreme they get to be. And if you find that when it comes to a person's manic presentation, if it is that extreme, it can never fall under BMD2, because it is that extreme, and the type of extreme that it can be is the type that can actually lead to a psychotic episode. But yes, there are instances where you find that a diagnosis may end up being readjusted, hence then the importance of continually having the follow-up sessions, because sometimes you may find that whatever a person presents with, just for example, your daughter already has a significant medical condition, and the practitioner who's attending to her would also need to look and see if there's an interplay between the medical condition dynamics as well as the actual presentation that she actually has. So yes, there may be times where you find that there may be a change that is then indicated.
Thank you so much. I just want to say she was diagnosed 3 years ago as having neurolupus. So that's why it's quite difficult and all these different things are happening. But the one thing that has been constant is that it started with a psychosis and a psychotic break.
Okay, no, that makes sense. Thank you, Wendy. And I think it's for that very reason why it was then placed on the BMD1 diagnosis, because of the psychotic presentation.
Yeah,
thank
you, Lucinda.
Thank you for that. I'm going to take one question from the chat box. And question is from Anonymous: where does anxiety feature on the mental wellness spectrum? May you kindly briefly speak on that too, following a format similar to that used for the first two topics.
All right. What I'll do is I'll just give a brief overview, because for me to do anxiety as I did with the others, I'll need to put in a lot of information. However, when it comes to anxiety is also in itself a standalone mental illness, and it's a disorder that we do diagnose. And there will always be an overlap between anxiety and depression. And I'll tell you why. When a person is depressed, they start to worry about the fact that they can't get themselves to be mobilized. And on the other hand, when a person is always worried, where they are always highly anxious, they then start to feel sad that they can't control the other symptoms that they present with. So when it comes to anxiety, for us to give a full diagnosis of, we would actually call it, it's a generalized anxiety disorder. But within that spectrum as well, there are other disorders that we would have, for example, like your social anxiety disorder. You would get your phobias, because those are all disorders that have got anxiety as being the predominant feature or the predominant symptom that they have. But when it comes to GAD, that is generalized anxiety disorder, what you would find is that a person's anxiety symptoms start to affect how the individual interacts with their environment. So just because I'm always worried, my functioning gets to be impaired. I don't want to go to work because I'm always worried. Sometimes there is a clear cause for concern that a person actually speaks to, but sometimes you find that there is none whatsoever, but the feelings of worry are always there. And with anxiety as well, you would find that there would also be the very same physical symptoms that a person would actually experience. And many of us can actually relate to this, where you find that you feel this knot in your stomach, you get hot flushes, you feel cold, and you start to have panic attacks as well, because that is another feature that we see when it comes to generalized anxiety disorder. So with anxiety as well, you find that functioning gets to be impaired. And how do we then get to treat it? We still go the medication route. But at the same time, because anxiety comes with a lot of worry, people then start to hold distorted perceptions. They start to believe, where you find that a person starts at times to even get paranoid, and they think people talk about them and the like. So psychotherapy then gets to be indicated as well, because then we want to start teaching the person tools and strategies that they can use to start challenging whatever thoughts of worry come to their minds, because such individuals would at times even catastrophize. One thing happens and the person starts to think everything is just crumbling down. So the treatment would almost look the same, but again, it depends on the severity, and that is what would actually inform what type of medication or what type of psychotherapies then gets to be given for that particular person.
Thank you, Lucinda, for that explanation. I'm going to move to our hand raised. I see there is a hand raised by Max. Max, you're most welcome to ask your question on the platform to Lucinda.
Evening, everybody. Thank you for Bestmed for this opportunity and the platform. I think this is a generalized question. It's difficult to put it all in words. So what I actually want to try and figure out, if there's a generational issue where anxiety and depression runs in the family. To use an example, for instance, my mom had depression and anxiety and panic attacks and went on medication and sleep therapy, etc. And she went through everything. And I basically grew up in a house with that. And she committed suicide when I was, I think, 18 years old, which obviously left scars. And obviously some days I do also realize that I have a little bit of anxiety and depression and a little bit of panic attacks coming now and again. But made the decision that I'm going to try and break the generational or this thing that's running in a family, if I can put it as such. But my biggest concern is we've got a 9-year-old boy, and is there any, so here comes the question, that was the history, is there any tools or anything that I can start doing now for him so he doesn't land up in the same situation. I know they say it's usually this type of stuff is in the genes and we can't change our genes, but is there anything that we can teach him or change ways that we do things maybe with him, or eating, or I don't know, whatever. I don't know, from a professional eye point, is there anything that we can do to try and avoid something like this happening to him in the future? That's my question. Thank you.
Thank you for the question, Max. As you rightfully said, when it comes to mental illness, sometimes it does come from genetics. However, it does not necessarily mean that just because one person in the family has had a certain mental illness that they were diagnosed with, it doesn't now mean that everyone in that particular family will have. However, what it does mean is that individuals are predisposed. If they were to be pushed far enough, perhaps with significant stressors, that may get triggered. But what would then help in terms of answering your question is, as young as he is, it starts with the family continuously being emotionally present, affording him a psychologically and emotionally safe space. And how do we do that? We do that by ensuring that each child knows that they are cared for, and they know that, for example, when they do wrong and they get reproached for doing something that is wrong, they know that there's basis for it. So meaning they exist in a family system that is supportive, that is loving, that is consistent, that is predictable, because lack of predictability and a lot of noise and chaos in a family system will trigger anxiety symptoms. It also speaks to also teaching your child, as young as he is, different types of self-care activities. And that looks like, get him involved in sports, eating properly, getting him to be emotionally open, getting him to actually engage with his peers, getting him to know how to function effectively within a social system. Because in the absence of that, that is when you find that perhaps children would end up bullying one another, or they end up ostracizing each other because they'll say, so-and-so has mood swings and therefore we don't want to play with him. So it's the little things, just by ensuring that the environment in which he exists is conducive and is emotionally safe for him to always express himself, so that growing up, if he's to ever experience any challenges, he knows that he needs to deal with a challenge as it comes, rather than bury challenges as they happen and they end up compounding to a point that one day he gets to be symptomatic. But does that mean that he would never? Not particularly, but because he would have a solid foundation around regulating his emotions, then this is someone coming into therapy, for example, if there would to ever be a need in future, this is someone that would be easy to work with, because he would already have a particular basis around certain acceptable behaviors. So more than anything else right now, to answer your question, support, 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 and deliberate support at that. Thank you, Max.
Thank you for the clarity. I appreciate it. Have a good evening.
Thank you, Lucinda, for that thorough question that you've actually answered quite well. I'm going to take one more question. I see that our time is slightly running out. So I'm going to take one from the chat box. And the next question is from Kutsia Swart. And his question is, how can you determine that depression is caused by chemical imbalances? Can the serotonin be measured? That's a second one. In that same question, is depression not just based on allowing your mindset to run rampage to create wrong thought patterns?
Thank you for that question, Kutsia. I'll start with the first part of the question in terms of how can one actually determine if it is caused by a chemical imbalance. Inherently, it is a chemical imbalance. It causes a chemical imbalance. So even if, let's say, a person gets depressed because there's been environmental factors that have affected them, the chemical imbalance would be there. And in terms of measuring, not that I know of, however, I noticed that on the chat box, the very same member also included quite a number of medications that are already on here. And that says to me that we're speaking to someone who's already seeing or asking about a person who's already seeing a mental health practitioner. And I would really recommend that that particular question is raised to the particular practitioner who's attending to them. And the reason why I say that is because for a start, what medication gets to be given and how much of it gets to be given depends on the severity of symptoms. It depends on the frequency of symptoms. It depends on age. And there's quite a number of variables, weight, etc., that actually get to be considered before a call can be made around what needs to be given. And as I said as well at some point in my presentation, sometimes you find that certain medications will not necessarily work at times. And so going back to the mental health practitioner to get a review also then becomes important. And then the last part quickly, where he says that is it not just based on allowing your mindset to run rampant to create wrong thought patterns? I would actually say no. For a person who's clinically depressed, how they perceive the world, what types of thoughts they end up having really is beyond their control. Hence us saying that they've got a mental illness, because their thoughts are now literally becoming, I'm going to say, for lack of a better word for now, chaotic. And that is where the interventions then come in to help them to start looking at things differently. So no, it is not something that an individual can actually control until such time that they have full awareness around what is happening and what causes what is actually happening with them. Thank you.
Thank you, Lucinda. Are we able to take one more question? We've got 4 minutes left. For a person who is an alcoholic, would you conclude that his shaking after heavy drinking is from anxiety or hangover? This person has been in rehab for alcohol 3 times and relapsed. Recently, he has developed seizures.
Okay. When it comes to that question, Guguletu, you need to understand that there is now a physiological reason to what is happening. For example, this person now has developed seizures, and we don't know what the cause would be. So for us to give an effective answer, really a full medical assessment would need to actually be done, because yes, a person can start shaking from anxiety, but you may find that there is a deeper physiological reason behind that. And as I indicated when I was presenting that, when it comes to us diagnosing mental illnesses, we'll firstly check, or rather would firstly exclude physiological or medical conditions before we can then say fully, this is actually anxiety. So yes, there may be an overlap where someone, yes, does get to shake because they are anxious and they've got generalized anxiety disorder. But for someone who already has this medical presentation, a medical assessment would be indicated first before we conclude in a psychological presentation. Thank you.
Thank you, Lucinda, for that answer. We've actually come to the end of our webinar, and we're going to close the question and answer platform. Thank you, Lucinda, for sharing your knowledge with us. Thank you to those who have managed to attend. That brings us to the end of our session. Thank you once again for attending, and we hope to see you for the next month's conversation.
Thank you.